So our first speaker is David Hassall, who will probably need no introduction from most of you. He's the Clinical Director of Pathology Department at Cambridge University Hospitals. He's published over 168 articles in chemical pathology and can be said to be the friend you call on when you're faced with a difficult thyroid function test. However, for today's talk, he'll be talking to us about the ins and outs of insulin assay in the diagnosis of hypoglycemia and other subjects which we can sometimes find to be quite tricky.
Thanks, Tricia. I'd like to thank the Society for the chance to speak and for the wonderful introduction. Slightly and somewhat nervously standing on the shoulders of giants to do this talk. I think most people consider that the development of the radioimmunoassay for insulin by Burson and Yallo was the birth of modern endocrinology. I think it accumulated in the mid-60s with Nick Hales from Cambridge inventing a robust immunoradiometric assay for insulin, and I was lucky enough to be able to work for Nick later on in his career. Since then, I think insulin assay has been slightly enigmatic. If you look at my own lab, we did 1/3 thyroid function tests last year, whereas we only did 2,000 insulin assays. And there are other things to measure, obviously. It's easy to measure and interpret glucose, C-peptide, pancreatic autoantibodies, and HbA1c. But I think now insulin assays have come of age. The main manufacturers have got credible insulin assays now that can run on our large automated assays. And these are very good for turning around very quick, very precise insulin results with a minimum of manual intervention. So what are we going to do with these new assays? I don't think anybody would argue in the use of insulin in investigating hypoglycemia. And I think most people would now also recognize the need to make the diagnosis of severe insulin resistance using insulin assay. So whilst I can't profess to be an expert in the signs and symptoms of insulin resistance, I can at least direct you to the Cambridge website and the email address within. So if you have patients with acanthosis, pseudoacromegaly, lipodystrophy, or accelerated growth, you might consider the use of an insulin assay to confirm the diagnosis of insulin resistance. I can talk a little bit about PCO. Our own severe insulin resistance service generates some spectacularly high female testosterone results, which always surprise us, but these turn out to be largely due to the insulin resistance alone. And I'll talk a little bit about measuring insulin later. So, standard phone call to the biochemist on a Friday afternoon. I've got a patient whose glucose is 3.2. What should the insulin be? This is obviously a very difficult question to answer because the relationship between glucose and insulin is possibly more complex than some of the other endocrine axes. So this guideline was very timely and has been very helpful for us to give some idea of what defines hypoglycemia and what insulin level might be associated with insulin as the cause of hypoglycemia. So I think we could probably argue the toss about whether we agree with the 3 millimole per litre cutoff for glucose, but one thing I think I can probably be almost certain is that most of the data came from this paper from the service lab. There isn't that much more data out there. And I think I can be fairly certain that the insulin assay you use is different from the assay that service used. Now, at the risk of alienating an audience of endocrinologists who are in general more interested in getting the right answer than the nuances of the assay that we use, for insulin, the assay you use is important. So this is work that was done by Gwen, who's in the audience, QA scheme, looking at insulin. So those of you who aren't familiar with this, it's a very simple but very powerful method for looking at assay performance. A central facility sends the same sample out to any laboratory who's interested in monitoring the quality of their assays. If you've never seen this before, you might be slightly alarmed to see the imprecision of the data, somewhere between 9 and 34 for this sample. But this is also a very powerful method for looking at method-dependent bias. So if you're using the Roche assay, and there's a high chance that you will be, you'll get a mean result of 30. If you're using the Imulite assay, you're going to get a mean result of 15. And I think Gwen probably chose this sample because this will drop either side of the service magic number of 18. So if you use the Roche assay, you're probably going to investigate more people for insulinoma, but I guess on the plus side, you're probably also going to detect more. So the second problem with immunoassay is that of specificity. Insulin assays were set up to detect the human insulin sequence, and in general, this is what they do. This is a common assay format, 2 antibodies set up against the alpha chain and the end of the beta chain, but unfortunately, this epitope is also the epitope that's modified in synthetic insulins. So this will affect the pharmacodynamic properties of the modified insulins to give a better therapeutic, but it will also affect the immunoassay. And you can see here, this is a study that was done by Tim McDonald's lab in Exeter that we contributed to. And you'll be quite pleased to see that all of the insulin assays will detect the native species, although I suspect you're not going to be too impressed by the reproducibility of these assays. But when you look at analogues, most of your assays are not going to detect insulin analogues. The only assay that detects most of them is the Macodia ISO insulin assay, and this was designed to do just that. This assay is available at Guildford and at Cambridge, but unfortunately it's not available on the big automated analyzers as yet. Looking at these data in a different way, if you look at your own method, let's say you're a Roche user, you're only going to detect the human insulin sequence. If you're an Immolite user, you will detect the human insulin species. You might also detect glargine as the pro-hormone, if you like, in this preparation, but it's no guarantee that you're going to detect the active metabolites of glargine. 2 other species that you're not going to detect is proinsulin and IGF-2, and these are both compounds that we know can cause hypoglycemia. Rather intriguingly, you're more likely to detect proinsulin using your C-peptide assay than your insulin assay, as most C-peptide assays have the same epitopes that are shared with the proinsulin assay. So this leads us on to the value of the insulin C-peptide ratio. Insulin and insulin C-peptide ratio. Insulin and proinsulin are secreted in equimolar amounts, so the minimum ratio would be 1:1. As the patient moves towards fasting, this ratio increases as insulin is cleared quicker than C-peptide, which will give you a fasting ratio of about 10 times more C-peptide than insulin. So this could be quite useful. If there's less C-peptide than you expect, this could be evidence for exogenous insulin. If there's more C-peptide than you expect, this might be evidence for proinsulin interference in the C-peptide assay. So moving on to other problems with immunoassay. Heterophile interferences, antibody interferences are an unfortunate fact of life for all immunoassays. Manufacturers have gone to a lot of trouble to eradicate this class of interference, but you may occasionally see a patient who has antibodies that's capable of cross-linking your immunoassay reagents in the absence of analyte. Unfortunately, our only defense against this at the moment is to be aware of the possibility of this. If you have a patient where you think this might be an issue, contact your own laboratory or Gwen's lab or my lab, and we can help you try and tackle this. The other class of antibody interference would be antibodies directed against not the assay reagent, but the hormone itself. I think the best studied example of this is macroprolactin, but macroinsulin also exists. I think everybody's aware of insulin autoantibodies and the pathogenesis of type 1 diabetes, and like many autoantibodies, they're also present in the normal population. But when does an insulin autoantibody become Hirata's disease? And this is when there's a sufficient amount of the antibody, or it has a sufficient binding affinity to affect insulin kinetics. The clinical sequelae of this can be very difficult to treat, hypoglycemia and hyperglycemia. So this is macroinsulin. Another class of interference you need to be aware of is that of biotin interference. Biotin is used as a treatment for inborn errors, also for multiple sclerosis, but I guess more difficult to detect is it's used in a lot of over-the-counter preparations. And if you're using an assay which uses the biotin-streptavidin linkage to catch the capture antibody, then this assay is at risk of being interfered with by biotin and giving a negative result. Clinical biochemists are discussing at length how significant this effect's likely to be, but again, if we look at some of Gwen's data, if you're using the Roche assay, this is certainly something you need to be aware of, and it's worth asking the question about over-the-counter vitamin supplements if you're measuring insulin using this assay. So I'll just try and sum up with two very quick case vignettes to cover some of the points I've mentioned. This is a case of proinsulinoma. And the reason I've used this case is to say it's a 79-year-old lady who had intractable hypoglycemia, only treated by IV glucose administration. And insulin was measured at the time of hypoglycemia, but if you'd measured insulin alone, I think you might have gone down the wrong path here. Insulin is less than the 18 magic number. What alerted us to this case is the very high proinsulin result. We then measured proinsulin and confirmed this was proinsulin cross-reactivity in the C-peptide assay. On CT, the patient had both liver and renal lesions, and this raised the suspicion of non-islet cell tumor hyperglycemia, but we ruled this out using Gwen's IGF-2 assay. Unfortunately, the patient succumbed. At post-mortem, she had a metastatic insulinoma in the liver. We never found the primary, with a coincidental renal cell carcinoma. The second case is a case of Hirata disease. Again, this patient presented with very difficult to control hypoglycemia. When insulin was measured, in this case, we see the opposite. This is a sky-high insulin result. If you look at C-peptide, the C-peptide is not as high as the insulin. This might lead you to think of exogenous insulin administration, but that C-peptide is still very high. And at the time, the patient had no access to insulin as they were admitted at the time. We were sent the sample to exclude assay interference. So we did a crude immunosubtraction with PEG, as is often used in macrohormones like macroprolactin. And we showed a very low PEG recovery. So this is suggesting that this patient has got insulin bound to immunoglobulin, which is causing this very high result. So to cut a very long story short, we were able to use size exclusion chromatography to separate the antibody-bound insulin from the free insulin, and we were able to show that we could exchange insulin into this antibody-bound fraction. So this proves the diagnosis of Hirata's rather than that of assay interference. So, to summarize, much as you probably don't want to, you need to know a little bit about your assay, particularly regards to its specificity and bias. C-peptide insulin ratio can be useful in determining the cause of hypoglycemia. Proinsulin and IGF-2 are likely candidates if insulin is not raised. Think about assay interference. If you're not thinking about it, then nobody is, unfortunately. So be aware that this can happen. Think about biotin and about antibodies. And consider Hirata's disease in cases where glycemic control is poor and you get a very high insulin result. A long list of thanks for people who've been involved in these cases and the analytical background to this. Last but not least, Gwen for letting me use the NEQUAS data and also her broad specificity insulin and big IGF-2 assay. And thank you all for your attention.
Thank you, David. We'll now move on to the next speaker, Professor Bill Fraser, who is the Professor of Medicine and Deputy Head of Norwich Medical School in University East Anglia and also a consultant in metabolic medicine. He has over 34 years of clinical experience and also over 30 years experience in developing new assays for clinical diagnostic use and research into bone and cancer biology. He's going to talk to us today about when and how to use PTHrP, 1,25-hydroxyvitamin D, and FGF23 in 12 minutes.
Yeah, 3 assays in 12 minutes. Thanks very much, Tricia. I've changed the order slightly because I think FGF23 is one of the molecules that's come to the fore recently, and probably many of you in the audience have cases of hypophosphatemia and are wondering what you should do about them. So I'll spend a little bit longer on FGF23 than the other 2 molecules. So, simple thing, where are the measurements performed? Well, we moved the SAS service, Super-Regional Assay and Advisory Service in Calcium and Bone Metabolism, to Norfolk and Norwich from Liverpool. That's the address there. My deputy is Alison Chip Chase, but you can contact me by email as well, and we'll be happy to answer any questions on any of the analytes that I mentioned today. When should you be measuring PTHrP? Well, it's in the investigation of hypercalcemia. Here's a simple protocol that I've published in several reviews. You can see here we've got the history and examination of a hypercalcemic patient, no obvious drug causes, repeat it because the lab sometimes gets the answer wrong. And then pivotal in looking and investigating hypercalcemia is PTH, and this is using the Roche assay. And so the middle of the reference range is a kind of cutoff value. I've yet to see a patient with primary hyperparathyroidism whose PTH measured by the Roche assay is not greater than 3 allied to hypercalcemia. So a PTH that's inappropriate for the hypercalcemia. If you've got that, yes, you're pretty well going down the route of hyperparathyroidism, primary being the commonest. Doesn't exclude malignancy. Remember that 12 to 15% of patients with primary hyperpara can have a malignancy present. So that's something to be aware of. You can use the calcium and creatinine excretion ratio to exclude FBHH. If we go down the other arm, however, non-parathyroid causes, hematological malignancies, other malignancies. Malignancy is often very obvious. You do a chest x-ray, there's a mass there, you've got a good idea of what's going on. But in many cases, you haven't a clue. And so then that's where a PTHrP measurement may be of value to you. And with the current assay that we use, a value greater than 1.8 picomoles per litre is a warning sign. Certainly to me, I think malignancy is highly likely under those circumstances. We can expand the non-parathyroid investigations out here, but again, going down the route of malignancy, is there a possible malignancy there? Is it a solid malignancy? Is it squamous carcinoma? They're very likely to have PTHrP elevated. And then you might go on and do some non-biochemical investigations. And of course, on the other side there, there's the other tests you can do to exclude other causes of non-parathyroid hypercalcemia. Many tumors do produce that factor, PTHrP. It's amino acid sequence. 13 of the 34 amino acids are identical between PTH and PTHrP. The R-Jarge lyse binding site is an identical position. So that's why the amino terminal PTHrP and PTH have similar effects, and that's what causes the hypercalcemia. And here's just the values that we get with the PTHrP assay in certain tumors, and you can see lung, breast, genitourinary. These are the commonest ones, and the highest values are seen in these particular tumors. Note, hematological malignancies don't produce PTHrP out into the plasma, but do have a local effect, and so a different type of effect of PTHrP, not out in the plasma, but a localized effect that causes the hypercalcemia. It's a bad news factor, PTHrP. If a patient has an elevated PTHrP and hypercalcemia, 97% of cases have a malignancy. I've reviewed over 500 test results, and only 3% have a non-malignant cause. And what are the non-malignant causes? Well, massive breast hypertrophy, seen in several cases, pregnancy in some cases, and I've got one case of a parathyroid that was removed and reported as an adenoma, had an elevated PTHrP, and I've been following that individual up for a number of years just to see if it happens to turn out to be a carcinoma, because some of those cases do happen like that. My money is on that being a carcinoma and keeping a very close watch on that particular patient. The average survival from diagnosis of that combination is 76 days. That's even with treatment of the primary tumor, so it's not a good news factor. And then the other aspect of this is if you have a patient with hypercalcemia trying to treat with bisphosphonates, the response is decreased and metastatic disease is present in over a third of the patients. And you can see the failure of response. Are they resistant to the bisphosphonate? Is there overwhelming malignancy? The PTHrP production by the tumors and coexistent primary hyperpara, the causes there to think about. And this is in the days when we had permidrinate, APD. You can see the difference between those with an elevated PTHRP and a lower PTHRP. This happened to be the Nichols assay we were using at the time. But those that produce PTHRP are much less likely to respond to a bisphosphonate, even zoledronate. I've got data that's the same as that. How do we measure it? You need to get in touch with us and get an EDTA plasma with peptidase inhibitors tube. Alison will supply that to you. We're quite happy to send it out. Separate the plasma, freeze it, and transport frozen. If you're really struggling and you feel you must send us a sample and you can't wait for the tubes, take an EDTA sample, rapidly separate it, freeze it, and transport to us frozen. Fibroblast growth factor, new molecule, 251 amino acid. These are all the cells that can produce it. It's the largest molecule in the FGF family. The major source is in bone, and you can see these osteocytes lighting up like coals in the snow. So the osteocytes are a major source of FGF23. What does FGF23 do? Well, it'll increase phosphate excretion, decreases your serum phosphate, and visits phosphate transport down in the kidneys. It'll also markedly decrease 125, so it's one of the causes of our lowering of 125 dihydroxy vitamin D. And if you knock out FGF23 in an animal model, you'll see the exact reverse to what's shown of the FGF23 effects. Its metabolism is important in terms of measuring the molecule. It's got this RXXR motif, 176 to 179, so that's a cleavage point. There's a lot of amino-terminal homology between the FGF23 molecules, with the C-terminals unique. The problem that this gives us is, of course, for immunoassays, because the intact assays for FGF23, there's an antibody in this company, Kanos won't tell you where the antibody is directed to, which is interesting. But they've got a capture antibody in the amino terminal and a detection antibody in the carboxy terminal. So you kind of look at that, and that's the whole molecule. And the whole molecule is the biologically active molecule. But then you've got some other assay formats, particularly the immunotopics assay, where the detection and the capture antibody are on the same bit of the molecule, the C-terminal, that fragment that's broken off. And just like with PTH assays, you run into the same problem in renal failure, which is interesting. So there's a current hypothesis. We've got active FGF23. I've shown the two colors there, the big molecule with a little bit on the end, breaks into an inactive FGF23 as a result of the FEX gene and changes. And this is important for disease. So we can diagnose patients with high FGF23 activity to have X-linked hypophosphatemic rickets. There's autosomal dominant hypophosphatemic rickets, where the molecule that's produced is an abnormal form and doesn't get metabolized properly, so it accumulates in the circulation. And then we've got tumor-induced oncogenic or osteomalacia, and those patients, you can see what happens is it's swamping the whole system by generating a high concentration of the FGF23 molecule. So we can measure the FGF23 molecule in cases of hypophosphatemia and get these diagnoses. And I would say to all of you, do review your patients, you clinicians, who are long-term hypophosphatemic patients, because you will have somebody out there who's got an FGF23 producing tumor. Send us the sample, then do the octreotide scan. We have to go into a PET scan to try and find the tumor. And people ask me, what's the lowest value you've ever had where a tumor was proven? The top end of our reference range is 100. And a lady came to me after I'd given a talk on FGF23. She said, thank you for doing the assay. It was 107, but the phosphate was 0.4. Same thing as with PTH. An inappropriate FGF23 for the circulating phosphate, and that patient had a tumor provenance octreotide scan and was removed. It's markedly elevated in renal patients, and there's a lot of studies out there looking as to whether we can treat patients early in renal disease and titrate them down with phosphate binders and improve the outcome in chronic kidney disease. It's a bad news factor in chronic kidney disease. High FGF23 is usually associated with refractoriness to vitamin D treatment. And you can see here how much better FGF23 is at picking up early changes in chronic kidney disease and reduced glomerular filtration rate. In clinical practice then, single sample, we need again an EDTA plasma frozen. Some people use it to do localization studies. If you've got an idea where the tumor might be, you can do sampling above and below, and just like for various other tumors, we can see a gradient across tumors and help localization. These days, there's other things that are becoming obvious. The reduction in use of phosphate in patients by monitoring the FGF23, titration of the vitamin D and its analogues in XLH, early use of phosphate binders in chronic kidney disease, and of course the tumor marker follow-up. Once the tumor's removed, you can follow up with FGF23, and the vitamin D sensitivity syndrome I'll talk about in relation to 125. So when to measure 125, we as biochemists kind of say don't measure 125, and I'll give you reasons why not to measure 125. We use it to investigate hypercalcemia, certain conditions, hypocalcemia, vitamin D resistance syndromes, and the vitamin D, what I'm now calling a vitamin D sensitivity syndromes. Do not use 125 to establish vitamin D status. Why not? Well, how to measure it? We measure with tandem mass spectrometry or immunoassay, but beware interference, especially in children. And here we have the classic production of 125. You can see here, skin, then liver, then the kidneys required to do the 1-alpha hydroxylation after the 25 hydroxylation in the liver. And this is the reason why you don't use 125 to assess vitamin D status. These are a collection of patients that I've made over time and followed them up for a period of time, and you can see the light blue is the 25 hydroxy D, and as it falls, what the body does is it strives to maintain your calcium within the reference range. And how does it do that? Well, it jacks up your PTH. What the PTH then does is converts more of the 25 to 125, and you can have a paradoxical situation where the vitamin D, the 25 hydroxy D, is actually dropped by almost 50%, but the 125, striving its hardest to maintain the calcium, is elevated. So you would go in, you would measure there and say, oh, measure the 125, you get entirely the wrong result. You would not realize that patient was becoming vitamin D deficient. So don't use 125 to estimate vitamin D status. The best measurement we currently have is 25 hydroxy D. Just a little table that I published in Teats recently, showing you what causes an increased 125. Granulomatous diseases, that would be sarcoidosis, TB will do it. Primary hyperpara will drive 25 to 125, because that can be a cause of an increase. Lymphoma, again, the presence of the 1-alpha enzyme system. And beware, some people can go out there and get hold of 125. You can get massive doses in America, huge doses of 125. And I've had patients who are guzzling it down like Smarties and end up markedly hypercalcemic as a result of intoxication. Then we've got the vitamin D-dependent rickets type 2, where 125 is elevated, but they're resistant to it. And then we've got this new syndrome that we're seeing now and seeing quite a lot of, diagnosing a 24-25 hydroxylase deficiency, and in those patients, 125, the value seems to creep up, and the ratio of the 125 to the 24-25 is a giveaway in idiopathic infantile hypercalcemia. Causes of a low one: renal failure, hyperphosphatemia, hypomagnesemia, hypopara, pseudohypopara, and vitamin D-dependent rickets type 1. You can keep loading them up with 25 vitamin D and sometimes get a response, but they're resistant to 125. 125 is low. Hypercalcemia malignancy, patients will inhibit the formation of 125 vitamin D. And then, as I've discussed in the previous section, FGF23 production inhibits the enzyme in the kidney, and that results in a low 125. So if you want to combine the two analysis, an FGF23 in a patient that's hyperphosphatemic with a low 125, that's a strong predictor that you may have tumor-induced osteomalacia. Lastly, I'd like to bring your attention to this. We've not been talking a lot about this in the vitamin D field because we couldn't measure it. We had lousy assays for it. The assays were all wrong. If you look back in the old literature, it says that 24-25 in many disease states was entirely normal. That's because the clinical biochemists were lousy at measuring it. Now we have a tandem MS assay and things are different. What we do now is have these ratios, and the 25 to the 24-25 ratio, the 125 to the 24-25 ratio gives information that the CYP24 regulated enzyme is absent or dysfunctional. In children, that can be seen as idiopathic infantile hypercalcemia, so it's no longer idiopathic. And in adults, if you give a young lady during pregnancy vitamin D, you force this system to produce more 125, no 24-25, and it's now been picked up as a cause of hypercalcemia in pregnancy. And also, in patients who are stone formers, we're finding a large percentage of patients have an abnormality in this ratio. So vitamin D sensitivity syndrome, the trick is to avoid giving vitamin D in those patients. Thank you very much for your attention. Hope to answer some questions.
Thank you very much, Bill. That was fantastic.